I'll go through just a couple of reminders while Dr. Shaw is getting set up. So as we just said, if you could keep your line muted when you're not speaking, that will help eliminate background noise, but please do not mute the IND line. That makes the tech people very sad and all of us cry in here because they have to re-sign us in. So please mute your own and not me. The meeting is also being recorded. Choose your words wisely as we go forward today. Make sure you don't say anything you don't want to. I will drive through the agenda and we will have roll call voting in order per usual. You can aye, nay, or abstain, but I will defer to Dr. Shaw through the agenda items as we go forward. And we do have a quorum. I think we're just waiting on potentially one other member that will join, but I will keep an eye out for her. So Dr. Shaw, whenever you are ready, we can begin.
All right. Thank you, Amanda. I'll go ahead and call the August 1st, 2025 meeting of the Therapeutics Committee meeting to order. I will go ahead and move on to the second agenda item and ask for comments from OMPP.
Good. Thank you.
All right.
Thanks for being here.
Yes, sounds like it's going to be a very exciting weekend with Gen Con and State Fair. So next item on the agenda is approval of the memoranda from the May 2nd, 2025 meeting at the T Committee. Are there any amendments to the minutes?
I'll make a motion to approve.
Okay, thank you.
Second.
Okay, the motions are made and seconded to approve the memoranda. Any further discussion? All in favor?
Oh, I got to.
Oh, sorry, we have to do roll call. Yes.
Dr. Shaw.
Yes.
Dr. Marshall.
He may be on mute.
He is on mute. If you want to.
Yeah.
Thank you. Mr. Musio.
Yeah.
Thank you. Dr. Opp.
I'll abstain. I wasn't there. Thank you.
There. Dr. Patel
Aye.
and Dr. Weber.
Aye.
All right, we have all ayes and one abstention, so that motion will carry. Thank you. Which should take us up to our review then.
Yes.
All right, let's get started. So for our respiratory recommendations, we have no recommended changes in the classes listed here. For the beta adrenergics and corticosteroids, the AirDuo Digihaler is no longer manufactured in CMS terms, so we need to remove that from the SUPDL. And then for AirSupra, we would like to maintain its current non-preferred status and current age and quantity limits, but add a step therapy for trial and failure of both Dulera and Symbicort as reliever therapy. And this really is focused on the updated GINA guidelines and the SMART therapy in that they have studied that LADAs with an ICS, specifically for Motorol, have a better outcome. And so they have those agents kind of in this first step, if you will, and then other agents that follow that. For the bronchodilator agents, adrenergic and anticholinergic combinations, the Spiriva Respimat, just the 1.25 microgram strength, will maintain its preferred status and quantity limit, but remove the step therapy requirement for the diagnosis of asthma. For the nasal antihistamines and nasal anti-inflammatory steroids, the Becanase AQ and Patinase are both no longer manufactured in CMS terms, so we need to remove those from the SUPDL. For the oral inhaled glucocorticoids, Flovent HFA, the brand only is no longer manufactured in CMS terms, as well as the Flovent Discus brand only is also no longer manufactured in CMS terms. So we need to remove them as well. For the pulmonary antihypertensives, the TAD leak suspension is moving to preferred and then updating its PA criteria around its step therapy requirements. And then Eutrepia is a new dry powder inhaler product, moving to non-preferred. It was previously in a neutral status, and then adding it to the PA criteria within the drug class. For the respiratory and allergy biologics, for Dupixent, maintaining its current preferred status, It does now have 2 new indications for chronic spontaneous urticaria and bullous pemphigoid. So we're adding those indications into the criteria. They do have step therapy requirements. Bullous pemphigoid around steroid therapy, and then the spontaneous urticaria around histamine blocking therapy. Updating the PA criteria for the COPD indication just to include the severity of COPD so that they have an FEV1 of 30% to 70% predicted. And then also adding criteria that they have to have documented signs and symptoms of chronic bronchitis, which can be chronic productive cough, for at least 3 months during the past year for the COPD indication. New CALA, maintaining its current status and updating the criteria to include COPD with eosinophilic phenotype indication. That's a new indication that we need to add as well. And then Xolair, updating its chronic spontaneous urticaria indication to include the additional step through adjunct therapies and or dose advancement of the histamine receptor antagonist. So having it match the Dupixent criteria just so they're all consistent. And then for all of these agents, updating their reauth criteria throughout, just that they are providing, the member has demonstrated a positive clinical response to therapy, whether that's stabilization or improvement in symptoms from baseline, and just making sure that they're having good response to the therapy that they're on. Any questions on that criteria or any of the respiratory agents? Alrighty, we'll move on to the anti-infectives then. No recommended changes in the classes listed here. For the antivirals, influenza and COVID-19 agents, amantadine and rimantadine are no longer recommended for the prophylaxis of influenza A, so they don't really fit in this class very well anymore. So we're just going to maintain them as neutral as they do have other uses. For the rimantadine, we will also remove its age limit. For the cephalosporins 3rd generation, the soup cracks, chewable tablets, and suspension, the brand only is no longer manufactured in CMS terms, so we need to remove that from the SUPDL. For the macrolides, the ZMax suspension is also no longer manufactured in CMS terms, so we need to remove that. For the topical antifungal, same thing with the Loprox kit, so we need to remove it from the SUPDL. And the topical antiviral and anti-inflammatory steroid combinations, we are proposing to remove this drug class altogether from the SUPDL and just have Zreese be in a neutral status with no quantity limit. You'll see some of our rationale during the second session of why that's supported, but we feel like since this product truly has been the only product in this class now for what seems like a million years and nothing else has really jumped in, we're going to remove it. Probably in a month, something else will come out and we'll have to add it back in. But at least for the moment right now, we're going to remove it and assume that nothing else is going to join it. And that concludes our anti-infectives. Moving on to cardiovascular agents, no recommended changes in the classes listed here. For the beta-adrenergic blockers, the Coreg, IR, and CR brand only are no longer participating in the MDRP, so we need to remove that from the SUPDL. And then for the low pressor solution, move to non-preferred. This is a new metoprolol solution, and then adding our usual step therapy that the member is unable to swallow the tablet formulation, supported by chart documentation. For the beta-adrenergic blockers with diuretics, Zyac brand only is no longer manufactured in CMS terms, so we're removing that from the SUPDL. For the calcium channel blockers, Kalin SR brand only is no longer manufactured in CMS terms, so we're removing that as well. And that concludes the cardiovascular agents. All right, for the lipotropics, no recommended changes in bile acid sequestrants. For the fibric acid derivatives, the Trilipix brand only is no longer manufactured, so we're removing that from the SUPDL. The HMG-CoA reductase inhibitors, atorvastatin, moving to preferred and maintaining its current step therapy around being 10 years of age or older and less than 12 years of age or unable to swallow the tablet formulation. And then for the lipotropics, there's a new product, Tryngolza, that we are moving to non-preferred and adding to the PCSK9 inhibitors and select lipotropics PA with its drug-specific criteria around its indication. And that concludes the lipotropics. For anti-migraine, the Alexiv moving to non-preferred and maintaining its current PA criteria and quantity limit. Nurtec ODT and Ubrelvy maintaining their current respective statuses and quantity limits, but we are going to update the initial criteria to include previous trial and failure of 2 triptan agents for the acute migraine treatment indication. So it was previously at 1, and we do feel like a lot of times triptans act differently in individuals, and so trying at least 2 is a very reasonable thing for individuals. And then Symbravo, this is the meloxicam rizatriptan product, moving to non-preferred, so it is new. It was previously neutral. Having a quantity limit of 1 bottle, which was 9 tablets per 30 days, and having a step therapy that the prescriber must provide documentation that the separate components are not suitable for use. And that concludes the anti-migraine. In the electrolytes, no recommended changes. In the MS agents, a couple of changes here. So Bafurtam was previously in a preferred 1-step position. We're now recommending a non-preferred 2-step position with a step through Vumerity first, even though Vumerity is non-preferred. So one of those 2 steps needs to be Vumerity. Ryumvi moved to preferred. It was previously non-preferred and then moved to the preferred 1-step criteria. This is considered one of the agents that's more highly active. So as we've talked about before, we're trying to have some of our more highly active agents either preferred or in the preferred 1-step for individuals to access. And that concludes multiple sclerosis. Of course, we saved the best and most changes per usual for last. Yes. There's a lot happening in here. So if you didn't notice, we appear to have approved approximately what feels like 25,000 biosimilar agents just for Stelara and Humira alone. So a lot of what you're going to see here is going to be movement of these agents. And spoiler alert, we are going to be going to some biosimilar adalimumab products only as preferred starting now. So hang on to your hats. There's a lot of movement, but we'll try and keep you on board with us. So the unbranded Hyrimoz, the adalimumab ADAZ, moving to preferred. It was previously non-preferred, so it's going to be in the preferred criteria. So this will be one of our preferred adalimumab products. And then the unbranded Julio, the FKJP, is going to be non-preferred in a 2-step position. And then just a reminder on our biosimilar criteria for what's in there. When we have them in the 2-step position, they do need to provide rationale for why they're not utilizing the preferred biosimilars. We do obviously check to make sure that all of the preferred biosimilars have the indications of the originator agent. So we're not forcing them to use a biosimilar that doesn't have all the same indications. So truly, since they are equivalent, if you will, products, we're kind of using a very similar PA criteria like we would for our brand medically necessary criteria for the use of the biosimilar. So just a little reminder there. All right, Ebglyss maintaining as non-preferred, but moving to a 1-step versus the 2-step criteria. And then we would update the PA criteria to remove the trial and failure of at least 2 other agents and maintain the trial and failure of ADBRI specific criteria. For Humira, I already mentioned this, it is going to a non-preferred position into the 2-step criteria. And I do not like this brand name. It's too weird the way they put these vowels and consonants together, but I think it's Imodolza or Dosa. It's the istacanumab, so a biosimilar for Stelara. It is going to go into the non-preferred 2-step position. And just as a reminder, Stelara itself, as the originator, already is in a 2-step position. Like Selby is moving to non-preferred. It's a new product. It'll be in a two-step position within the criteria. Nemluvio will move to non-preferred. It was previously preferred. It's going to go to a one-step position and maintain all of existing PA criteria. Chiva will move to preferred. This is again another biosimilar for Stelara, and it will be in the one-step position. So just to point out, as well on the slide, Stelarzi and Chiva will be our two preferred Stelara biosimilar options. They are going to be in a one-step position, whereas the Stelara and other biosimilars will be in a two-step position. Rinvoq, we're going to maintain its current status, but it has a new indication for giant cell arteritis indication. So we're just making sure we add that into the criteria. For Simlandi, another Humira biosimilar moving to non-preferred into the two-step position. Trembia maintaining its current status and adding its new indication of severe Crohn's disease to the criteria. Tyenne maintaining its current status, but adding its new indication of cytokine release syndrome. And then Usimri is also a biosimilar for Humira and moving it to the non-preferred two-step position. So for, as I kind of already talked about this already, but for all of the non-preferred two-step biosimilars for Stelara, as well as Stelara, their criteria will require previous trial and failure of all the preferred ustekinumab products, which again, I mentioned is Pyzchiva and Stelarzi, and or that the provider has provided some medical rationale for use for as to why they cannot use those preferred agents. So very similar to our brand preferred criteria. And the prescriber, sorry, not anymore. And the prescriber has provided valid medical justification for use. And then before I go on to new business, so just if you were trying to keep track too of what biosimilars for Humira we're now having on board, it should be Hadlima for the high dose, as well as the adalimumab product. I'm trying to remember what its last initials were. Quick. I think, yes, the ADAC. Yes, the unbranded Earpods. So those two are going to be in your preferred position. And Hadlima does have a high and low concentration available. I'm quite certain. Yeah, so we will have one low concentration product available with Hadlima. We have very little utilization of that, which you'll see when we get to that slide, and then you'll have two high concentration products available. We did also have Michael confirm that Hadlima could Hadlima the world if they needed to, as far as having enough stock available. So we should not have any concerns or issues with stock that we've had with some of the other biosimilars. Any questions on that? Because I know that was the meat and potatoes of this presentation right there. That was the meat and potatoes of this presentation right there.
Hi, this is Dr. Marsh. I just got one question on that meloxicam triptan. You say that if they can't take both of them, they can take one. What instance is that going to be? That you can't take both of them, but you could take one together?
So it should be pretty rare, and my assumption would be is that there's some issue with that they can't swallow those separate tablets, or that there's issues maybe with the inactive ingredients of that agent that they need to do that, or they're having some issue with being able to take those two tablets together. It should be incredibly rare if ever happen. Incredibly rare if ever happen.
Okay.
Any other questions? All right. That takes us up to new business in the agenda. Any new business from the committee today before we talk about our favorite topic, opiates? All right, I am hearing none, so we'll go over some of our opiate data for June. There was just a slight increase from May, and we had kind of noticed this little steady step down for a little while, and now we're kind of noticing a little steady maybe increase, which I'll show you in the graph. I don't know that I have a whole lot to explain for it, except that during the summer, we do tend to see like increases in elective surgeries, especially in kiddos. So around like tonsillectomies and wisdom teeth and all those fun things that people try and get done before school starts. So we do see like some of the really short supplies increasing. So the new opioid utilizers and really low doses and then falling off. So we'll just kind of continue to monitor that. Our less than 18 tends to be really consistent on the day supply, always less than around 5 days. So we're still looking pretty good there. As far as those over to the right, again, you'll notice everybody above 500 and above has been PA exempt. We're working our way down through the lower doses. And again, the vast majority of our patients are in the less than 90. So we get some pretty small numbers in the other groups. If we're looking at our trending overall, this is the above 90 group. So again, really small numbers of individuals in this space. When we look at our overall trending, so again, you can kind of see that kind of steady decrease that kind of went all the way to probably about the March, April timeframe. And then May and June, we've kind of ticked up a little bit. Again, aside from, kind of summer elective things, I don't know that I have a lot of other explanations, but we'll just continue to monitor it. It's still very within line with where it's been. So not anything overly alarming at this point, but just something that we're kind of keeping an eye on. Just a reminder, the greenish color at the bottom is our current utilizers that are adults over 18. The cranberryish color is the new utilizers, and the purpley blue at the top is those that are under 18. So you can notice the under 18 increased just slightly kind of in that May, June timeframe, and the new utilizers also increased kind of just slightly. The current utilizers have stayed relatively steady. If we look at the overall trending by dose, you can see the less than 90 really holding very steady. And again, that just slight increase in the May and June timeframe, but really overall pretty steady. And then when we look at kind of everybody 90 and above, again, these are really small numbers, so just a little bit kind of changes them, but really what we expect to see is what has been happening. You might notice that there's been like an uptick kind of there in the April, May timeframe of the 250 to 500, which is what we would expect as we've kind of moved people down in doses. So we've expected people to fall in that range as they've fallen out of the higher dosage range, and we'll just continue kind of working our way down and continue to make headway. We're over halfway there. We started at 1,000 and we're now at what, 400? 350. Yeah, so we're over halfway. We've made good progress on our way down. Any questions on the opioids?
So Amanda, I was taking a look at the I guess the PA. On page 10, yes. That discusses concurrent opioid and benzodiazepine therapy. What I would understand from this document under the notes is that individuals on concurrent therapy are only required to go through the PA once, and otherwise they are exempted from the criteria. Is that correct? Because it says current utilizers of benzodiazepines and opioids concurrently will be exempted from PA criteria at this time.
So if they're current from the sense of current qualifies as like 90 days of the past 120 days. So if they have that continued use already, we've kind of continued to allow that continued use. And that's from the very inception of this PA because we knew we weren't going to move those people off very quickly or right away. So that's kind of been the next step that we've had hanging out is what we're going to do with these current utilizers who have been on both therapies long-term and how we're going to address them. For those that are like, let's say you have a newer start, we're not, unless they have really valid justification for using both agents, and usually it's more like end of life terminal type situations, they're usually not getting to that current status. And we're truly talking about people who have been on both for years, and
Right.
years and years at this point.
Right.
But we would definitely love you guys to start noodling on what we're gonna do with our current analyzers, because it's been, I know we've talked about it a lot with Dr. Ott too, on the mental health quality advisory side. They've talked about it in the sense that, these patients are hard to move off either agent, right? Very difficult and potentially dangerous to move off either agent, depending on how you're approaching it. As far as, just stopping individuals cold turkey. So that's been something that we've been kind of trying to figure out long-term how we're going to address.
Right. I mean, the reason why this is sort of an issue that is a relevance that I find particularly relevant is the fact that I have a patient where I share concurrent care with the provider in a long-term care facility, and I've been trying my best to discontinue the benzodiazepine, but I'm just getting a lot of resistance from the provider because from their perspective, there's no obstacles or barrier besides a certain provider who is being a thorn in their side. So,
Yeah, I think it's going to be the case that we really got to think about, which agent are we going to try and go after to discontinue? I mean, the argument is, right, when you think about long-term use really of both agents, there's not a lot of data that suggests long-term use of either agent is really valid, if you will, or provides benefit, except for, maybe those few exceptions. Yet we have a lot of exceptions, right, apparently, that are on both agents long-term. So, and stopping either of those agents is a very real and difficult thing to manage. And so we've kind of put it on hold as we've been doing the MME. So we kind of took the approach of let's get the MME down to, the 90 where CDC and everybody is recommending. Then once we get the 90 MME down, which again is taking us years, so it looks like we're, moving at a snail pace, then we can kind of start approaching, okay, what do we start using? What do we start doing about some of these people who have been on these therapies long-term? And whether that's we address it through the concurrency or address it through benzos in general and long-term therapy and addressing opiates in general and long-term therapy. So there's definitely multiple ways we can kind of come at that approach as well. I see Dr. Ott's wheels turning. Did you have feedback, Dr. Ott, that you wanted to provide?
I'm going to start turning my camera off. So yes, you were correct about that. Damn it. So I think one of the things that why it's hard for me to kind of cogitate around a broad perspective for this is that I don't have a good handle on, and I'm not sure anybody does, on what's going on with these folks that requires this long-term use. So, I mean, I'm kind of wondering if it's not where we put together a group of folks that are willing to look at some percentage of these folks in a deeper dive in their medical records and try and ascertain why before we try and put something in place that will broadly impact folks that might be more negative than we hope for. Does that make sense?
Yeah, I think so. Courtney was just talking to me and I agree. A lot of the ones that we end up approving on our end, again, we mentioned are either end of life issues and, we're talking cancer, et cetera, or what we've noticed is spasticity becomes a major issue with folks. Like, so those who have like chronic spasticity issues that need pain control and like relaxation of muscle, right? And so they have major issues with that. That's what we have approved. That's not necessarily all the like thousands of people that have been continuing therapy since, the dawn of time, right? That are on both that can't stop either one.
Well, I think one of the challenges with benzos is that there's, historically for the last, 20 years, it's been benzos are bad. They have an effect size greater than the SSRIs for anxiety. So there is a subgroup of people who do respond much better to benzodiazepines. And so I think those are the kinds of things that have to be taken into account as we consider this.
Well, I think part of the problem here, Dr. Ott, is the fact that the issues pertaining around concurrent use of these classes of medicines is limited to the outpatient setting. That the medical licensing board exempted long-term care facilities from these from the requirements and oversight, and consequently, it's not very high on their radar screen like it has been for people who practice in a hospital environment, an emergency room environment, or an outpatient environment. And that's part of the obstacle, is that I just see a lot of concurrent utilization of muscle relaxants, benzodiazepines, and opioids in long-term care facilities because they've never had any particular attention or focus placed on them.
Do you know, so that's a really good point. And do you know, has any discussion, or I don't know if OMPP knows if any discussion has occurred with the medical licensing board about including LTC facilities or why they've exempted them and potentially bringing them into the fold?
I think the initial discussion was really the fact that medications are dispensed in those environments, so that the risk for an accidental overdose was less. But it never really addressed the appropriateness of the safety risks that are associated with the concurrent use of these classes of medicines.
Because that would be a population of people highly at risk for that combination.
Yes, particularly frail and comorbidities.
I mean, that's something I'll take it back with the OMPP later that we can discuss if that's a recommendation maybe that the committee can work on and send to like the medical licensing board or something, that here's the reasons why we think this group should be included in the guidelines that they're applying.
We can take that back.
Population, we do include that population with our criteria though, so, like, yeah, I understand that.
Yeah. But the prescribers, I see what you're saying, like from their perspective, like, well, I don't have any guidelines around this, so why are you telling me I have to do this?
Right.
Mhm. Any other comments on opioids? Thank you for that discussion. All right, this is an FYI only. So as of 7/1/25, all interchangeable biosimilars. So again, this means they have all the indications, et cetera, they're considered interchangeable. Released and added to the drug file will be placed in the same status category with the same utilization management as their respective originator products. So kind of like we've come up with historically, when we've had, generic agents released when there's a brand, we're basically just saying as these come on, we're going to go ahead and add them in versus kind of leaving them loading out in the ethos. And then we'll review them at the next cycle when we bring them. Any other new business that we need to go through?
So if there's a future adalimumab, JARXK, they will be automatically placed in the same category as, I guess, the brand name adalimumab.
Right, until it's been used for pricing, right? Any other questions before we move? We have a full public comment schedule today. So I do have one comment that I want to make about public comment. Just for everyone, we did add some language to the public comment sign-up sheet around disclosing any payment gifts, however you want to look at it, for a manufacturer for which you are going to speak. We have noticed that maybe there are some folks that either don't think about that or haven't listed that. And so there is a website through CMS where you can check payments from manufacturers. And we've listed that on there as well, so people can check for themselves, just in case you too might have forgotten that you received a payment from somebody and could see that. So if somebody has received payment within the last 2 years from a manufacturer on a drug of which they are going to speak, they most certainly can still register for public comment. That is not a problem, but we want that box to be checked. And we do limit the speakers to 2 speakers per drug. Those that are not compensated, we don't have that same limitation too. So just wanted to point that out, that we are just kind of tweaking the language a little bit for our future public comment. All right. So let's get started. Our first one up is Dr. Dubé for Air Supra.
Hello, can you hear me?
Yes, we can.
Okay, I'm just going to let you know for Lokelma and Fasenra, I will not need to speak. I'm going to give my time back as they are both preferred. So for Air Supra, good morning. My name is Chris Dubé. I'm a pharmacist within medical affairs employed by AstraZeneca. I want to thank you for the opportunity to present information on Air Supra, albuterol, budesonide, lighter dose inhaler. The information I discussed will do support the approval criteria for the movement of Air Supra to stepping through the preferred beta agonist short-acting class versus the beta agonist and corticosteroids agents based on indication for rescue therapy in the state of Indiana. It is a fixed dose combination inhaler containing both albuterol and budesonide indicated for as needed treatment or prevention to reduce the risk of exacerbations. Air Supra is the only rescue agent available in the U.S. with the added indication to reduce the risk of exacerbations. Inhaled salvas have historically been the treated choice for rapid relief of acute symptoms. However, high use of asaba alone for the relief of asthma symptoms may worsen inflammation and increase the risk of exacerbation and asthma-related costs. GINA guidelines have recommendations for the use of an ICS inhaler. Recommendations stress the importance of treating the symptoms and the inflammation of asthma to provide recommendations for rescue therapy, and they do not recommend SABA therapy alone. The most recent 24 recommends the continued use of a SABA as needed and an ICS in a separate or combination device. Several aspects to keep in mind when reviewing the GINA Smart Therapy. First, the SMART concept only includes inhalers that have a combination and taken into account. And as we look at that, we know that in track 1 for GINA, that is a smart therapy. The GINA recommendations for the use of ICS formoterol as risk are primarily based on clinical data using a budesonide formoterol formulation that is not available in the United States. Air Supra is intended to be used as a rescue therapy of acute symptoms alone or on top of an ICS LABA. Maintenance therapies such as Symbicort or Dulera in the United States and not in the place of the agents. And last, I'd like to call out to the committee, the FDA package insert for Symbicort and Dulera have a important limitation that it not be used for the relief of acute bronchospasm. In closing, as a reminder, Air Supra is a rescue therapy. I would like to take any questions now as we ask for it to be stepped through preferred agents of a beta agonist short-acting versus the combination agents.
Any questions from the committee? All right, thank you very much. Next up, we have Dr. Vedkardi, which I believe he is in the flesh in the room.
Can you hear me through the microphone here?
Yes.
All right. All right, I'll go ahead and begin. Good morning. My name is Neelish Nadkarni, pharmacist in Mosul for AbbVie. Thank you for the opportunity to speak today regarding a Togepan brand name Qulipta. The request is for the committee to change the number of injectable MAB failures from 2 to 1 prior to receiving oral Qulipta. Qulipta is an oral once-daily CGRP receptor antagonist indicated for the preventive treatment of migraine in adults. The AHS 2024 position statement recognized Qulipta as a first-line preventive option in addition to oral generics such as topiramate. Since the AHS position statement, new evidence has come out by way of the phase 3 Temple study, a global multi-center randomized double-blind, double-dummy, parallel group active controlled trial. Qulipta demonstrated superior tolerability and efficacy compared to topiramate for the preventive treatment of migraine, and all 6 key secondary endpoints were superior compared to topiramate. There were no new safety signals seen with Qulipta, and the overall adverse event profile of Qulipta in this study was consistent with safety findings from previous studies. The results of this head-to-head study support the AHS position statement on Qulipta as a first-line preventive treatment option. Furthermore, the AHS states that the cumulative evidence for the efficacy, safety, and tolerability of CGRP targeting therapies is significantly greater than that for any established migraine preventive therapy. Therefore, the CGRP targeting therapies should be considered as a first-line approach for migraine prevention, along with previous first-line treatments, without a requirement for prior failure of other classes of migraine preventive treatment. QULIPTA has one contraindication, a warning about hypersensitivity reactions. Most frequent ADRs reported in the phase 3 trial were nausea, constipation, and fatigue somnolence. This was an abbreviated review of QULIPTA. Please refer to the PI for more information. And for the reasons covered here today, respectfully request the committee to change the number of injectable mAb failures from 2 to 1 prior to receiving oral QULIPTA. Thank you. I am.
Questions from the committee on QLIPTA? Should you take it away for Skyler?
All right. Let me grab a sip of water. I'm sorry. All right. Can you hear me okay? Yeah, great. Good morning. My name is Neelish Nadkarni, pharmacist in Mosul. I'm going to speak for risankizumab, brand name Skyrizi, for which I'll refer to as Riza throughout this testimony. Today, I'm requesting the committee to consider moving Skyrizi from non-preferred to preferred on the PL. Riza is an interleukin-23 antagonist with 4 indications across rheum, gastro, and derm. These 4 indications include adults with moderate to severe plaque psoriasis, active psoriatic arthritis, moderate to severe active Crohn's disease, and ulcerative colitis. Riza offers several clinical meaningful attributes. First, in clinical trials, Riza demonstrated durability and skin clearance with long-term response and the ability to achieve rigorous treatment targets, including PASI 100 or 100% skin clearance in plaque psoriasis, minimal disease activity in psoriatic arthritis, and endoscopic remission in chronic progressive inflammatory GI disorders, Crohn's disease, and ulcerative colitis. Treating to the target of endoscopic remission, as recommended by the STRIDE 2 guidance, is associated with improved long-term outcomes and may reduce the risk of bowel damage. Second, Riza has consistent efficacy in difficult-to-treat populations, such as those with high BMI, those bio-experienced, or those with severe disease. Third, Riza achieves superiority in all primary and secondary endpoints in head-to-head trials in psoriasis against 4 advanced therapies with different MOAs: IL-12/23 inhibitor, TNF inhibitor, IL-17 inhibitor, and a PDE4 inhibitor, and superiority to an IL-12/23 for endoscopic remission at week 48 in Crohn's disease. Safety profile of Riza is established across indications with up to 9 years of clinical trial experience starting in plaque psoriasis. Riza may increase the risk of infection. Patients should be evaluated for TB prior to initiating treatment with Riza. Avoid use of live vaccines while on treatment with Riza, and there's a warning for hepatotoxicity in the treatment of IBD. This was an abbreviated review of Skyrizi. Please refer to the PI for more information. Respectfully request the committee to consider moving Skyrizi from non-preferred to preferred on the PDL. And again, thank you again for your time, and happy to answer any questions you may have. All right, thank you. Appreciate it.
Next up is Dr. Mehta for Zimbrava.
Okay, perfect. Can you hear me?
Yes, we can.
All right, thanks so much. Okay, so good morning. My name is Jay Mehta, Health Outcomes Liaison at Axsome Therapeutics. Thank you for the opportunity to provide information on Zimbrava. That's a recently approved novel oral single-dose medicine approved for the acute treatment of migraine with or without aura in adults. Zimbrava represents a multi-mechanistic approach to treating migraine that targets multiple pathways underlying the symptoms of a migraine attack. Zimbrava consists of Mosaic, meloxicam, and rizatriptan. Mosaic stands for Molecular Solubility and Enhanced Inclusion Complex and is Axsome's proprietary rapid absorption technology. Mosaic formulation results in approximately a 5 times faster median time to max plasma concentration for meloxicam while maintaining a long plasma half-life. In the pivotal phase 3 Momentum trial, a single oral dose of Zimbrava provided rapid freedom from migraine pain and most bothersome symptom at 2 hours post-dose, as well as return to normal functioning at 2 hours and sustained pain freedom through 24 hours. In addition, 85% and 77% patients treated with a single dose of Zimbrava did not use migraine rescue medication within 24 hours in the Intercept and Momentum trials, respectively. So regarding the step therapy, of note, the FDA-approved labeling of Zimbrava, that's section 2.3 in the PI, states that it is not substitutable with other formulations of meloxicam or rizatriptan, even if the milligram doses are the same or similar. And this has to do with the Mosaic technology for meloxicam, which changes the Tmax from 5 hours to 1 hour. Therefore, you cannot simply use individual components to comprise Symbravo. Most common adverse reactions in the controlled studies were somnolence and dizziness, remaining reported each in 2% and 1% of patients in the Symbravo and placebo arms, respectively. As with all prescription NSAIDs, Symbravo carries a boxed warning for risk of serious cardiovascular and GI events. Please refer to the full PI for further information. In summary, Symbravo is a novel oral multi-mechanistic migraine treatment that addresses important clinical unmet needs, should be considered for preferred status on the PDL for the Medicaid beneficiaries in the state of Indiana. At a minimum, the step therapy language should be changed. Thank you very much. Happy to address any questions.
Dr. Maida, what is this mosaic technology you're talking about?
Yeah, so thank you for the question. So with Symbravo, we have mosaic technology. So for meloxicam, which you're familiar with, that's Mobic. So what we're using is a cyclic carrier molecule with a pH buffer. So as I mentioned, that changes the normal Tmax for meloxicam from 5 hours to 1 hour. 5 hours is obviously not going to work when someone has a migraine attack, which is why meloxicam is typically not used within migraine. However, with this technology, now we can utilize the benefits of an NSAID, which obviously addresses additional things mechanistically in terms of neuroinflammation and central sensitization, along with the triptan, rizatriptan.
So this carrier molecule that alters pH increases Tmax, is what you're saying.
Well, yes, the Cmax is increased and also shortens the time to max concentration for predominantly meloxicam, but also we see a little bit of effect with rizatriptan as well.
Okay, thank you.
Thank you.
All right. Next up, we have Carla McSpadden with Nemluvio.
Yes, hi, can you hear me okay?
Yes, we can.
Great, thanks. So my name is Carla McSpadden. I'm a pharmacist employed by Galderma. Our request for Nemluvio is to just have a step through any atopic derm biologic, not a specific step through Adbry. And our rationale for this request is that Nemluvio offers a different mechanism of action. It's an IL-31 inhibitor. It's the first drug to target IL-31, which is implicated in itch, inflammation, and skin barrier disruption. Second reason would be for the clinical benefits, the clinical value. It's shown significant itch relief within 48 hours after the first dose, and significant skin clearance and sleep improvement within 4 weeks. It's also been well tolerated in the trials, has no warnings or lab monitoring requirements per the PI. And then last rationale would be the potential financial value associated with atopic derm responders, extending the dosing interval from every 4 weeks to every 8 weeks, as recommended in the PI. Nemluvio is the first atopic derm treatment with every 4-week dosing and maintenance dosing of every 8 weeks for responders, which is different than all other biologics for atopic derm. So we respectfully request again a step through any atopic derm biologic, and I'm happy to answer any questions.
Any questions? All right, thank you very much. Next up, we have Dr. Melby with Bimzelx.
Yes, thank you. Good morning. My name is Rick Melby. I'm a PharmD with UCB, and I'd like to update you on important clinical information on bimekizumab, or Bimzelx brand name. This is a humanized IL-17A and IL-17F antagonist with 5 indications. I'll start with PSO, the clinical program, and as a reminder, in phase 3 treatment with clinical trials, treatment with Bimzelx produced rapid, complete, durable responses, with PASI 90 results being superior to placebo, Humira, and Stelara, and PASI 100 results were found to be superior to placebo and Cosentyx. All these were at week 16. In PSA phase 3 trials, treatment with Bimzelx produced rapid and sustained responses. ACR 50 responses, the primary endpoint at week 16, were significantly improved versus placebo in both DMARD naive and TNF alpha inadequate responder patients. In NR-AxSpA and AS phase 3 clinical trials, BIMZELX produced rapid, deep, and maintained responses. ASAS 40 responses were the primary endpoint at week 16, and they were significantly improved in both subjects with NR-AxSpA and AS versus placebo. And finally, in phase 3 studies in HS, treatment with BIMZELX produced rapid, sustained, and maintained responses. HiSCR 50 responses, the primary endpoint at week 16, were significantly improved with BIMZELX 320 milligram every 2 weeks versus placebo. Patients treated with BIMZELX had rapid responses compared to placebo as early as 4 weeks. Safety information, there are no contraindications, no box warnings, no REMS program. The most common AEs were upper respiratory tract infection, oral candidiasis, and headache. So we'd respectfully ask that you would place BIMZELX in a non-preferred single-step position on your PDL, and I'll take questions here. Thank you.
Any questions for Dr. Melby? All right. Thank you very much.
Thank you.
Next up, we have Dr. Odabayi for SOLARSI.
Yep, can you hear me all?
Yes, we can.
Great. My name is Mima. I'm a pharmacist with Teva Medical Affairs. I'm here to provide testimony on SOLARSI, a biosimilar to Stelara. Stelara is approved in the following presentations: 90 and 45 milligram pre-filled syringes and 130 and 45 milligram vial. The FDA reviewed the application for SOLARSI's interchangeability with Stelara and has waived the requirements to complete a separate interchangeable switching study. SOLARSI is interchangeable with Stelara in all available presentations. An interchangeable biosimilar may be substituted at the pharmacy without intervention by the prescriber. This is subjected to state pharmacy laws. SOLARSI is an interleukin 12 and 23 antagonist approved to treat all the indications covered by the reference product Stelara. A phase 3 multi-center double-blind 52-week study was conducted in 581 patients with moderate to severe chronic plaque psoriasis to compare efficacy, safety, tolerability, and pharmacokinetics between patients treated with SOLARSI and Stelara. The primary endpoint of the PASI % improvement from baseline to week 12 was 87.3% for SOLARSI and 86.8% for Stelara, which were within the therapeutic parameters in accordance with FDA criteria. Safety profiles remain largely unchanged and similar between the treatment arms after switching at week 16. Most of the treatment emergent adverse events were mild to moderate in severity and were considered unrelated to the treatment assignment. At week 16, there were numerical differences in the ADA and NAB frequencies, though they had no clinically meaningful impact on the study's treatment, efficacy, safety, or PK profiles. So with that, we at Teva respectfully ask the members of the committee to make SOLARSI available to patients within Indiana Medicaid as a preferred drug. And I see it is being recommended as preferred. So I want to say thank you for that, and I'll take any questions.
Any questions? All right, thank you very much. Next up, we have Dr. Sumner with Dupixent.
Hi, can everybody hear me?
Yes, we can.
Awesome. Hi, my name is Lauren Sumner. I'm a pharmacist and associate director of medical value and outcomes at Sanofi. I'm here to share with you the impact Dupixent has had in treating type 2 inflammatory conditions. It's currently the only biologic in this space with 8 indications, which are atopic dermatitis, asthma, chronic obstructive pulmonary disease, eosinophilic esophagitis, chronic sinusitis with nasal polyps, prurigo nodularis, chronic spontaneous urticaria, and bullous pemphigoid, highlighting the breadth of its utility to treat conditions impacting patients from their lungs to their skin. I'll focus on 3 key conditions that pertain to today's agenda: atopic dermatitis, asthma, and COPD. Dupixent is a unique biologic that targets the underlying inflammation in these conditions by inhibiting interleukin-4 and interleukin-13 signaling. This dual mechanism of action has shown impressive results in both clinical trials and real-world settings. I'll start with atopic dermatitis. The PROS registry, a large-scale real-world study, has provided compelling evidence of Dupixent's effectiveness. In patients 12 years and older, we've seen significant improvements in disease control for up to 3 years. What's particularly exciting is the data for children aged 6 to 11 years with severe atopic dermatitis. In clinical trials, Dupixent combined with topical corticosteroids showed significant improvements in skin clearance, introduction, and overall disease severity, with 33% of children achieving clear or almost clear skin after 16 weeks of treatment, compared to only 11% with standard therapy alone. Even more impressive is the long-term data in adults showing sustained efficacy for up to 3.5 years, the longest duration of data for any biologic in moderate to severe atopic dermatitis. This long-term efficacy is crucial for chronic condition like atopic dermatitis, where sustained control is often challenging with traditional therapies. Turning to asthma, the real-world evidence is equally compelling. The U.S. Advantage study demonstrates that Dupixent significantly reduced exacerbations in systemic corticosteroid prescriptions in patients aged 12 years and older with moderate to severe asthma. This is a game changer for patients who have long struggled with frequent asthma attacks and the side effects of chronic steroid use. Moreover, long-term data from the Traverse open-label extension study showed sustained lung function improvements in patients with a type 2 inflammatory phenotype. Importantly, Dupixent has showed efficacy regardless of patient susceptibility to allergens, making it a versatile option for a broad range of patients. When we compare Dupixent to other biologics on the market, its dual efficacy in both atopic dermatitis and asthma sets it apart. While direct head-to-head comparisons are limited, the real-world evidence suggests that Dupixent offers a unique combination of efficacy, safety, and long-term disease control that many other treatments struggle to match. Treatment for COPD has a breakthrough in the past 12 months with the approval of Dupixent.
Dr. Sumner,
I'm sorry.
your 2 minutes is up. Sorry.
That's okay. Thank you for listening, and I'm willing to answer any questions.
So what is your request, Dr. Sumner?
To take the new information into account, and when I was going to get to the COPD, just take the new information for real-world evidence into account when evaluating the product in terms of comorbid conditions, and then when I was going to get to COPD, just evaluating it in comparison to the new evidence with Nucala.
Okay. Yeah, I believe Optum's recommendation is to add in the new indications.
Understood. Thank you.
But wait, there's more. We have another page. All right. Next up, we have Ms. Harine, I think, for Air Supra. I don't readily see them, so I think we'll go on to the next one then. Dr. Rosemarin for Ebglyss. Maybe I scared them all away. All right, we'll continue down the list then. Dr. Riato with Tremfya.
Hello, good morning. My name is Tamara Rito, and I'm a pharmacist with Johnson & Johnson Innovative Medicine. Thank you for the opportunity this morning to speak to you about Tremfya, guselkumab. My comments today were in support of adding the new indication for the treatment of adult patients with moderately to severely active Crohn's disease to the targeted immunomodulators PA criteria. As this has already been discussed on the agenda, I yield my time back to the committee. But thank you for your time and consideration today, and I'm open for any questions if the committee has any.
Thank you. Any questions? All right, thank you very much. Next up, we have Dr. Coates with Air Supra. You didn't see Dr. Coates.
Hold on. Okay, go ahead.
Hello. Hi, my name is Dr. Charles Coates. I practice in Fort Wayne, Indiana. And Air Supra, I found to be an excellent addition to my practice because it actually extends the time that patients don't actually have to go to the hospital when they have exacerbations of their asthma. But it also, for a lot of patients that are difficult to get them on maintenance, it actually provides a little bit of the maintenance benefit. However, in my practice, I'm having a particular hard time getting it approved. Right now, when we currently attempt to get it approved as a rescue inhaler, which it is FDA approved for, we're getting a kickback from the state who says it is a maintenance med. Last year, we had the same problem, but we were able to show them the PI, and they were able to see that, no, this is indicated for rescue and not maintenance. However, this year, even though we can show the state that it's FDA approved for rescue, not maintenance. The state continues to insist that it's a maintenance med and that it then chooses to use the other maintenance meds that actually are on formulary. I have no clue how to correct this, but what it is doing, it increases the amount of patients in my practice that end up going to the hospital with exacerbations of their asthma. You know, I would like my patients to actually be on their maintenance and then use rescue as necessary. However, as a practicing physician in my community, I actually got to meet my patients where they are. And like my goal is to actually, one, decrease their abuse of the hospital, their abuse of rescue meds, but two, to actually give them, especially with the weather the way it is, stability in their chronic disease of asthma. If there's, and I don't know how or why you guys have it listed as maintenance and not rescue, but if that could be alleviated, it would actually help everyone, the patients, because their disease will be a lot more stable. The cost to Medicaid, they won't abuse the ER system, and it would just make my day wonderfully easier. Thank you.
Certainly, we'd be happy to see examples. I don't know where, at least from a fee-for-service perspective, I know we're not sending out anything saying Air Supra is maintenance, but it could be happening on a managed care site. I don't know unless I see examples. So my email is up at the end of this, and I can certainly throw it in the chat. If you want to send me examples, I can forward that as appropriate. What we are finding.
So I can definitely forward that to you. We have numerous versions of it.
Yeah, that would be great. And what we are following is the GINA guidelines that recommend use in kind of their track 1 approach of using Symbicort and Dulera as both maintenance and being able to be used for rescue as well, so that they don't have to have 2 separate inhalers, one for maintenance and one for rescue. So that's what we're recommending as the
only
first line
problem
based
with
on
that is when you put it that way, now they're using their Dulera 200 4 to 6 times a day. And I'm not sure if there's ever been any studies that show using Dulera 4 to 6 times a day would be beneficial. The same problem was with Symbicort when it was actually branded on the market. Patients loved that because they were using it like a rescue. And actually, neither one of them actually showing abuse that decreased actually them going to the hospital. It actually led to more lung actually damage and problems. So although that seems like ideal, but in my patient population, especially, that's just not practical what we see. I think a lot of things like that, those are great studies and great things to do and highly educated or university-based research studies, but it's not something we see in practicality out in the community, especially in underserved areas.
Appreciate that feedback. We'll definitely have to think about that and take that back. I wish, unfortunately, our pulmonologist that's on the committee is not here today, so she definitely would have been able to provide some additional feedback. So apologies that she was not able to make it with us today, but we'll, committee members, any other questions that you would like to ask for that? Or for Dr. Coates today?
Amanda, you're saying
Or for
that,
Dr. Coates today?
yeah, Amanda, this is Dr. Marshall. You're saying that you'd rather them use the Symbicort preparation instead of Air Supra for rescue in that instance? Is that what you're saying?
Yeah, so based on the current GINA guidelines for asthma, they stay in track 1 to reduce exacerbations and morbidity and mortality to utilize Symbicort or Dulera. And they don't necessarily call those products out. They say ICS for Motorol, okay? They say, which just happens to be Symbicort and Dulera. So they say utilizing an ICS for Motorol has better outcomes for individuals to use for both maintenance and rescue. And then if that is not tolerated or they don't do well on that, then their second track or track 2 is to then go to a ICS SABA.
Mm-hmm. And this Air Supra is FDA approved for a rescue, but what were we saying that they're running out if they use Symbicort? There's not as many puffs. Is there a difference in puffs in each between Air Supra and a Symbicort-like inhaler?
So Symbicort has the LAVA, the long-acting beta agonist, the formoterol, versus Airsupra has the albuterol component, the short-acting beta agonist. And so that's that ICS LAVA combination is what was recommended in track 1 by GINA for SMART guidelines. That's what they have first. Then they have we'll say Airsupra, ICF SAVA, and in track 2. So clinically, we looked at it that way. There's also evidence that we'll provide in the closed session 2, that will also kind of support our recommendation as well. And so we're not saying that they can't
There
get
are
to.
different inhalations between each inhaler.
They can't get to the amount of inhalations.
What is the inhalations
We're
of each
looking.
inhaler
We're
between the two?
we're looking.
Okay.
Just one second. I can't remember off the top of my head which all 3 of them are.
Were there long-term studies of using like Dulera or Symbicort multiple times a day? I mean, we're talking about 8 to 10 puffs a day, and not showing harm. Like I'm saying, over a year, over 6 months, or over 3 months. Are there studies that like that I'm not aware of?
Yeah, so I mean, not that I'm aware of, but we're following the guidelines. And I think the idea is that hopefully if people are if you can get people controlled, right, on their controller med, and they're using their controller med for rescue, that hopefully they're not having to use 8 to 10 puffs a day if they escalate their dose up appropriately. That I think is what the guidelines are saying and looking at, but I am not aware of studies that look at that.
Most of those patients aren't well controlled, and that's why we're having a problem. And I'm not familiar with FDA approving the use of, or even studying the use of Dulera or similar-like compounds where they're doing more than 4 puffs a day. Because I don't think that's ever been studied long-term. But we're suggesting that we do that when there's no long-term studies.
So their indication is up to 12 inhalations per day for both Symbicort and.
Over a year?
They can use up to 12 inhalations per day for long-term utilization per the GINA guidelines. We just pulled them.
I wouldn't encourage that.
No, but it can. And until the guidelines.
I mean, again, the GINA guidelines are very clear. So within each track, there's also multiple steps where they'll say if you're at this severity or this severity, and you continue to step up to obviously higher doses, so that hopefully, again, once you continue to use that, you won't be having to use 12 puffs per day. And those individuals that aren't controlled, I guess at that point, is it because they're not utilizing their inhaled corticosteroid properly?
I'm sorry, but someone just I had to pull up the GINA report, but that's based off of data and strengths and formulations that weren't available in the U.S. So correct?
I'd have to go back and research it. I'm not sure.
I'm pretty sure. Adapted from the 2024 GINA report, the use of ICS formoterol is not approved for the maintenance and rescue therapy or as a needed rescue only in the U.S. The recommendations for the ICS formoterol are based off of clinical data evaluating the use of ICS formoterol formulations and strength, not approved and not available in the U.S.
So you are correct. It is not an FDA labeled indication to be utilized for rescue. However, that's just because the manufacturers haven't gone and requested it, basically, or they're in the process of requesting it.
But we're suggesting that doctors go against it. Use off-label, and we be protected if there's any damage.
Because so in the space of Medicaid, when we talk about reimbursement, we talk about FDA-approved labeling guidelines. We talk about or FDA approval, we talk about approved compendia as well as guideline recommendations. And the GINA guidelines are very clear on how they lay out which drugs individuals should step through first, even though they don't have the indication. There's lots of drugs all the time that don't have FDA approved indications that get used.
Well, no, I get that, but it doesn't necessarily mean it's the best thing for the patient. I give you, we use hydrochlorothiazide as a first-line hypertension, but not because it's the best thing for the patient or the patient benefits from it. We use it because it's cheap. You know, if you have a person with a blood pressure of 160 over 90, they're probably going to need at least 2 or 3 medicines to get them actually to go. But we start off with hydrochlorothiazide because it's cheap, not because it benefits the patient. With diabetes guidelines, we use metformin first line, even though actually we know that they're probably going to use more medicines and incretins will work better. But we're not using it for the benefit of the patient. We're actually using it because it's cheaper. I understand what you're saying, but I'm just saying in this cases, the guidelines are looking at the cheapest, not necessarily the most beneficial way for the patient, and actually are not looking at the long-term cost of the disease in the long run. And I'm saying we're already dealing with difficult to treat patients who are already non-compliant, because if they were compliant, we have plenty of maintenance meds that will work extremely well with them. But part of the problem is they're not compliant, they're a little bit more difficult, and what we're trying to do is stabilize their disease while also effectively making them more compliant, and that's where Air Super helps. I don't see doing, I mean, for years I've encouraged my patients not to abuse the Symbicort or not to abuse the Dulera, but it's kind of like now we're telling them to go ahead and abuse it.
We're not required 8 to 10 puffs per day.
No, I mean, so
Trying failure.
Yeah.
so I can't speak to how all other practitioners practice, but I can tell you from a Medicaid perspective, in the diabetic space, we actually are recommending incretins and SGLTs first line based on certain indications as the guidelines recommend. So we do try to follow the guidelines as closely as possible. And as far as compliance,
well,
I'm struggling.
I know, and the guidelines do change, and the one that changed for the SLGT2s was recent after new information came out, actually, given that they're non-insulin stimulating. But, you know, I'm just saying that the guidelines aren't always, you know, for the most effective treatment for the patient. A lot of it's cost, which I get. But in this case, I think we're being short-sighted and not looking at the extraordinary cost of them visiting the ER and the extraordinary cost of the damage being done to the lungs that we're going to pay down the road, where this, you know, has numerous studies that actually show, and me in my clinical practice have seen it decrease the ER use and actually stabilize patients. That's
Dr.
my
Coates. Yeah, Dr. Coates, this is Dr. Shaw, the chair. What I would say at this point is it's very clear that you are a passionate advocate for your patients and for their well-being. What I would advise you to do is for you to come back during the third session, which starts around 11 o'clock, so that the committee can respond in a more informed manner after our executive session.
And thank you for your time, and I really do appreciate that. And I'm going to definitely try to do that, but I'm also in the middle of seeing patients right now. We just kind of carved out, and I have patients actually in the room waiting. But I'm going to try and make that. But thank you again for at least giving me the time and opportunity to express my feelings.
Yes, and then, you know, regardless of the outcome, I would, you know, encourage you to reach out to Amanda. Her email will be attached, or
right, and I'm going to send her some of the denials so she can see what I mean.
Perfect.
And again, thank you again for your time.
Okay. Thank you. Appreciate your time as well. All right, I don't see it. I think it's Dr. Bikak. Is somebody on for Dr. Bikak that maybe I didn't see? All right, and then I think our last one is Dr. Kabir. Didn't readily see them either, but I haven't. Is there a Dr. Kabir on the line? All right. Anybody else that was on this list that maybe joined after we went through your name? Okay, I think that takes us through public comment then. I'll leave this up just so people can see the email there as well. Any other business this morning before we go to the closed session? So just a reminder, if you are in the room, we ask as politely as possible that you get out so that we can get started. And then, because we are actually we're in overtime right now. So normally we would start at 10. So those that are on the phone from the committee, you should have the closed session in your email. You can click on that closed session. We'll go to that meeting. We'll give people like a good 5 minutes. So if you need to take a bio break, please do. And then for those that are joining the third session, just of note, because we're starting a little behind now, we may very likely be starting behind in the third session. The third session is at this same meeting invite at 11. But again, if we're not there right away, we will join as soon as we finish the second session. And we will start with the third open session at that time. Thank you, everybody. And we will see you back a little later and see others on the second session.